nice, and I want to congratulate you. I want to congratulate you for your perseverance, for continuously involved in process of teaching. And today our topic of discussion is concepts of stereotactic neurosurgery. The stereotactic neurosurgery is not a new concept. It was basically started. Dr. Asad, I would be comfortable if I will run this lecture.
मैम
Means
एक्चुअली
I want to scroll.
मैम मैं आपको होस्ट करूं, लेकिन एक्चुअली रिकॉर्डिंग कर रहा हूं, इस वजह से थोड़ा रिकॉर्डिंग में प्रॉब्लम हो जाएगा। तो अगर आप मुझे नेक्स्ट कह देंगी तो मैं आगे कर लूंगा मैम। रिकॉर्डिंग कर रहा हूँ ना इसकी, इस वजह से।
Okay, okay,
जजाकल्ला मैम।
okay, fine. So I will. Okay, so basically, I am Prof.Dr. Fauzia. I am head of department at Allama Iqbal Medical College, Jinnah Hospital, Lahore. Um, Functional neurosurgery is a very good field because you can get the results immediately regarding tumor, regarding dystonia, regarding biopsies. So it's a nice field, and the concept. Next, please. The concept of neurosurgery is not new. Next slide, please. The stereotactic neurosurgery was started in the early 20th century. The concept was to reach the depth of brain with a 3D concept of accessing the lesion so that with the help of a 3D coordinate system, so lesion can be accessed at eloquent, deep-seated areas. And basically, at that time, it was started for movement disorders, and they made different type of these and these frames. And the first frame that was made, that was of brass, and its cost was almost 3,000 pounds. And then in that way, in the early 20th century, the stereotactic neurosurgery was started. Next, please. As I already alluded, basically the it was started for taking biopsy. Stereotactic catheters. We can use this for biopsies, for taking biopsies that are the lesions that are present in the depth of brain or in eloquent areas in the brainstem. And we can place catheter while utilizing this. These catheters can be placed either in case of hydrocephalus, in slit ventricles. We can place catheter like Omaya reservoirs. We can give the we can place catheter for brachytherapy, for interstitial therapy. In the depths, the electrodes can be placed for detection of the this epilepsy focus. For they can be placed for lesion generations, like in the DBS, in the GBI, you can make a lesion. You can aspirate while utilizing a specialized case of the screwed cannulas like the Archimedes screws for evacuation of intracerebral hematomas. Stereotactic neurosurgery is quite advanced nowadays. We can even use this technology for making a flap prior to make a flap and to localize that lesion. There are certain areas where it's still in experimental and form, and it's one day it will be gradually more evolved, like for the placement of the fetal adrenal medulla cells into the brain for Parkinson's disease, It's for laser therapy. It's in experimental studies, and also in cases of the clipping of the aneurysm, it's in experimental trials. Next, please. Basic contraindication, the absolute contraindication is the coagulation disorders, the coagulopathies. Whenever there is coagulopathy, means if the platelet count is less than 50,000 per milliliter, it's absolutely contraindicated. And ideally, it must be more than 1 lakh for performing this stereotactic procedures. And all those patients, even with a bigger lesion, if you want to establish an histopathological diagnosis, then even then you do this under local anesthesia. So all those patients who are not fit for GA, we can do something in them for regarding aspiration, for establishing diagnosis. We can utilize this stereotactic procedure. Next, please. So basically, there is a renaissance. There is revival of neurosurgery. This stereotactic neurosurgery, there is revival when the in movement disorders in Parkinson's disease specifically, the dyskinesias and the side effects they were diagnosed in the late 20th century, then again the stereotactic neurosurgery revived. And this but the principle remained the same. The principle neurosurgery is that you have to use a 3D reconstruction Cartesian coordinate system in which which can be utilized for precisely identifying a target with brain. And this Cartesian system is usually resides in the frame. And in the frame, these fiducials, they are utilized as a reference. They make them a reference. We can detect the target, and then we can do all kind of stereotactic procedures, either if you want to do a biopsy or whatever you want to do. Recently, a frameless stereotactic biopsies and frameless stereotactic procedures are also in practice, in which basically here you can appreciate this frameless system in which there is no need of a frame on the head. Placing a frame on the head is a very cumbersome procedure. Many patients are very reluctant and they cannot carry this frame and to do the CT or MRI, whatever the media you will select for taking the image with this frame. So in those patients, this frameless system in which the target can be selected either by using the antenna having the spheres on it, or by using the fiducial on the surface of the scalp, and they can be detected with the help of this infrared camera. In this way, a 3D model reconstruction will be on the screen, and we can detect our target, and we can go for any stereotactic procedure. Next, please. Next, please. So the basic principle of stereotactic, back, please, back. The basic principle of this, in the back slide, please. The basic principle of the stereotactic procedure is that you have a system, either a frameless or a frame-based system, in which the frame will be placed on the head of the patient and frameless system will be attached with the patient's position, in which, with the help of that software, you have to detect target. When you detect target, software will give you an access. You will select an entry and then you will select your trajectory. In that way, you have an access to your target and you can do kind of neurosurgical stereotactic procedure. Next, please. It's cumbersome for me that I am not changing my slides. I want to change myself. So next time, please make something easy for the presenters so that they can change the slides by themselves. So basically, these are the different types of these are different kinds of these frames, and different frameless systems are also available. The frames which are available, we all are familiar, even in our country, the Lexel system, CRW, RD frame, ZM frame, all are available. In frameless navigation based system, we are using Medtronic system, Brain Lab system, Striker system. Whatever the system you are using, you must have mastery of that. You know what is the software, how you can utilize that. If you are using a frame-based system, how to apply that system. In the frame-based system, basically, the trajectory is limited. And in frameless system, the whole, that circumference is in front of you. And there is liberty to use a free trajectory. But the frameless system is less precise as compared to frame system. In frame system, the margin of error or the specificity or the sensitivity is more and more accurate as compared to the frameless system. Next, please.
او يخدك كورتا راغلي مونږ چاته ویل نه دي کنه چې مونږ را لښه تا ته مې وی او دا خلک به راځي ډاکټر.
So basically, in the planning for any stereotactic procedure, stereotactic neurosurgery, the ACPC line has a pivotal role. AC, the anterior commissure, and PC, the posterior commissure. Basically, this line and their mid-commissural point, the reference to this line gives us the basic reference for detection of a target in the body. Whenever any target, like for example, you want to take a biopsy in this patient, you can detect multiple targets at the periphery, in the center, on the right side, on left side, whatever the target you will select, this ACPC line will give you the basic your reference anteriorly, anteroposterior, mediolateral, and craniocaudal these readings, so that this is your target and you can select that target. So basically what I want to convey, the ACPC line has a pivotal role in the stereotactic neurosurgery. Next, please. Here this is the lesion. One most important point is that basically either you can use the CT or you can use the MRI. With the help of CT as well as with the help of MRI, you can detect your ACPC line, you can detect your target, you can find out your actual position of this target, and you can select your XYZ for position of that target. Basically, the MRI gives more precise nature of the lesion. Here on the CT, the lesion is not precisely defined here. So what the most of the surgeons do, even the second point is that with the help of MRI with frame, it's difficult for the patient to remain in the MRI suite for 30 to 45 minutes for MRI. But CT can be done easily. So what is our practice? We already achieve an MRI having all the anatomical details about the lesion or about our target for any stereotactic procedure. And then we apply a frame on the head of the patient and do a CT. This CT scan, here you can appreciate these are the fiducial. As this is a CRW frame, so every system has different fiducials. In CRW frame, the fiducial system 1, 2, 3, you have to detect them. The ZD frame, they have their different fiducial lines. So while taking the CT scan, it's mandatory that all fiducial must be visible on the scan so that you can use them as a reference. So after that, in your software, you will merge. What we do, we merge all this CT with these fiducial with the previously obtained MRI and get a mm, merged picture and then identify our target. After selecting the target, here again, you can see here on the screen, even in the software, you have to enter and you have to select your anterior commissure and posterior commissure. As I already mentioned, these have very important role for giving us a reference within the brain surface for a target so that we can get our XYZ, the anteroposterior, mediolateral, and craniocaudal, all the attachments so that we can uh, select our target. Next, please. So in that way, here, this is the 3D reconstruction picture. Here you can appreciate this is the MRI. And here you can select even, you can appreciate here plan 1. Plan 1, if you will select a target here. In the next, then software will detect all the credentials, all the important readings regarding its position laterally, how much the target is laterally, anteroposteriorly, or craniocaudally placed with reference to this ACPC line. And then you can change into plan for making another target at another place. So here, after selection of the target, you can set your entry. Entry, wherever you will select, you can select your trajectory, select your entry point, and then select your trajectory. The trajectory is selected, in which we scroll over here all the way down to look for any sulcus, because vessels usually resides within the sulci. So trajectory should be like this. It should avoid any sulcus. It should avoid passing through the ventricular system, and it should avoid to pass through the eloquent area of the brain. In that way, this all you can achieve, your software will tell you where you are and what type of what position you will set on your frame. So you can do all this. And with planning and then selection of target, then selection of the entry, then selection of the trajectory, you can achieve all the readings. Moreover, it gives you the reading of the ring as well as the arc. So how much you have to move that. In frame-based system, as I already mentioned, the trajectory is limited and more precise. While in the frameless system, you have liberty of your trajectory and you can place anywhere. Next, please. Next, please. So here I want to share few of my cases. Back, please, back. So in the first, this is very cumbersome for me. Okay, let's see. In this patient, this is a suspected lesion. Lesion is at the base and there is too much edema here. Yes, they are not sure, the radiologist is not sure about the diagnosis. We apply, this is the ZD frame system, the Inomate system. We applied this frame And this is the fiducial containing. These are the fiducials. These lines are the fiducial. And this part of the fiducial brain then apply on the head of the patient. Patient was shifted to the CT scan room. The CT scan was achieved, and then this fiducial head was removed. This frame was attached with the frame or arc, and then we took a biopsy, and it turned out to be a low-grade glioma. Next, please. This lady, this was her picture. She was medically unfit, seems to be some glioma, and she was on medication for her chest pneumonia. So what we did, here it appears that probably this is very superficial, but in reality, in the coronal section, this was not so superficial. Again, with the help of ZD frame and then applying the fiducial frame on that, we did CT merge with the preoperative MRI, select a target, do a stereotactic biopsy. Unfortunately, that turned out to be a WHO grade 4 glioma, and then we sent her for radiation and chemotherapy. Next, please. This was very interesting case. This young girl, probably 10 to 11-year old, she presented to us with this horrible lesion. You can appreciate here. And it was documented by the radiologist as a peanut tumor. I try my best to look for any excess, but it was purely thalamic, and there was no corridor to reach that lesion. Then I decided to take a biopsy. Patient was fine, just she has a typical thalamic hand and some dystonia in her right arm, focal dystonia. So I applied this ZD frame, do the stereotaxy. Patient was lucky. It turned out to be a granulomatous inflammation, and then we started her on steroid and ATT, short course of steroid along with ATT, and she is in our follow-up. And after 2 years, her this lesion has been vanished in the MRI, and she is fine. The dystonia has improved, although with some residual weakness in the arm, in her right arm. So we even published this. Next, please. Published this case in the Surgical Neurology International, that a case of focal dystonia in ataxic hemiparesis as the initial presentation for thalamic tuberculoma. She was immunocompetent. She was not immunocompromised. And she was fine, even no history of family history of tuberculosis. Next, please. So basically, I just shared a few cases. In the same way, as you can get an access to a deep-seated lesion for taking biopsy, in the same way, the abscesses, they can be aspirated. So even in this era of judicious use of third generation, where the patients, even for sore throat, they are taking for heavy antibiotics, still the contagious spread as well as their hematogenous spread is very common. And when you will diagnose, there are multiple wound-enhancing lesions or a single lesion in a patient, then in a deep-seated location or in an eloquent area, you can go for aspiration of that abscess. Next, please. So these are the few example. Apparently seems, although in it's very quite common, it's not so small. In so much big lesion, even we will prefer to go for the aspiration by open method. But you can aspiration with stereotactic aspiration is an option, and you can go for that aspiration of that abscess. And at certain areas where you are not sure whether these are the tuberculous abscesses or whether these are pyogenic abscesses or whether this is glioma, even you can utilize this stereotactic aspiration for brainstem lesion. Either you can use a supratentorial route or you can use a transcerebellar route where the lesion is peeping into, and you can establish a diagnosis. And if patient will be lucky, patient can take antibiotics according to not only the confirmation of the diagnosis as well as the culture sensitivity from that pus, that will help us in the management of the patients, as well as if patient has malignant lesion, then you can refer them for radiation and chemotherapy. Next, please. So aspiration has the same technique, the utilization of the same principle, application of the head frame on the head of the patient, making a burr hole, and then use the software to detect the target. And then after detection of target, you will select your point of entry. You can select your trajectory, and then this is after aspiration of the abscess, only probably the capsule. And this is not done by us. This is taken from the Google. The pictures were taken. The idea was to give you an idea that aspiration can be achieved with these stereotactic method. Next, please. Next, please. In the same way, the as the organizers, they gave me the four things to cover in the lecture: the stereotactic biopsy, the aspiration of the abscess, the placement of the depth electrode, as well as the pain management. So I try to touch all of them. The placement of depth electrode is not easy to make a decision to place a depth electrode. These decisions are usually made in all those centers where a dedicated epilepsy unit is present. That is a unanimous decision of the neurophysiologist, neurosurgeon, the neuropsychiatrist, neuroradiologist, and they have to meet on that. And when the patient having very specific history of seizures, you want to detect a epileptogen focus, and patient is not responding to any kind of medical treatment, and you want to do surgery, or if you want to know a focus simply, then in that case, if there is failure of the surface EEG, or if there is failure of the video EEG, in that case, the decision is made to place the depth electrodes. The idea is same. You will fix the head, you will apply frame, you will, this probably utilized with just fixing of head with the help of the frameless system, in which you will select a epileptogen focus in the brain. Next, please. So a huge flap is taken. A craniotomy flap is performed. Then dura is reflected. The important thing is that the stereotactic procedure is utilized to detect the point of entry and trajectory. Remaining procedure is always open, and care should be taken to look for any draining vein on the mesial or basal surface of the head to avoid any inadvertent bleeding. So what usually the procedure is, after detection of epileptogen focus, then usually the sulci and the sulcal vessels, they are avoided, eloquent area is avoided, and a small PL dissection is made to place the electrode in the depth. This is the grid, which is again multiple. These are the contact points for these electrodes, and then they are placed in such a way that they keep all these electrode in place. Next, please. So after that, all the electrodes, they should come out from in such a way with a watertight dural closure. And then in the same way, they should come out through the burr sides. Here you vigilant on the skin from the separate incision. And in that way, the wound is then closed. And you can then attach with the EEG. Next, please. And you can, next. So back, please, back, back. Your person appointed on changing of back, back, please. So this is the EEG that was achieved from the surface electrode that was normal. Next, what I realized, the person that is appointed on that change of either has hypokinesia or hyperkinesia, not normal kinetic person.
मैम माफ
So
कीजिएगा,
when
मैं
you
कर
will place,
जी
no, that was on just a lighter note.
जी मैम
So
जी.
these are the depth electrode, you can get abnormality. So that I want to show you. The surface electrodes, they will show you the normal EEG, but epileptogen focus can be achieved from the depth electrode. Next, please. Our next area, which I would like to cover, is the pain. We know that the pain is perceived at the periphery. At the periphery, the physical and chemical painful stimuli, they are basically converted or transduced into an action potential. They are processed in the dorsal root ganglion, and then second order neuron, they are transferred to the brain, where in the ventral posterolateral and ventral posteromedial nucleus, they receive all the pain stimuli. For the olfaction, all sensations, they are received in the thalamus. That's why it's called the relaxation. It first processed and then send all the information to the sensory cortex of the brain. From the sensory cortex, again, it descending inhibitory pathway. They again modulate this pain via the brain stem back into the spinal cord. Next, please. This is basically the thalamus. Thalamus. A neurosurgeon must know for all the procedures to be performed, he or she should know the anatomy as well as the physiology of the different part of the brain areas. Thalamus, anterior nucleus, this is just for interest. We all know this has relationship with the limbic system. The dorsomedial part, this is basically for behavior. This is the motor part of the thalamus, the ventral anterior and ventral lateral nucleus. This is basically the sensory part of the ventral posteromedial and posterolateral nucleus. The ventral posteromedial nucleus, it basically take all the trigeminal lemniscus, the second order neuron from the face, head, and this posterolateral nucleus, this receives the spinal lemniscus, the second order neurons from the whole of the body, from one side of the body. So this is the target for the pain management. And this pulvinar and medial and lateral geniculate, they have their own specific relationship with the visual apparatus and this for the auditory apparatus. So basically, in the thalamus, this is the area of interest regarding pain. Thank you. Next, please. So basically, we all are familiar that there are different procedure or there are different choices for pain. Either first thing, it's necessary to establish whether the patient has pain that is unilateral or patient has pain that is bilateral. Patient has pain unilateral, then again, there are different options. If the pain is below this diaphragm level or below this C5 level, then Cordotomy is the procedure. In the same way, here, these are the procedures of choice in bilateral commissurotomy. But in bilateral, it's better to give narcotics either below diaphragm or above diaphragm. The stereotactic ablation or stereotactic lesion or stimulation making role is an upper extremity role, whether you want to stimulate it or you want to make a lesion, one either in the thalamus ventral posterolateral nucleus or in the mesencephalon. Then stereotactic procedure can be utilized. Next, please. The mesencephalon target is usually in at the level of the superior colliculi. It's almost 5 to 8 millimeter below the mid-commissural line, and it's 5 millimeter lateral to the midline. Here in this procedure, the patient is a diagnosed case of cancer of lung, and he has severe pain in the right upper arm. So the selection of target was this ventral posterolateral nucleus. The ventral here, the target was planned according to the ACPC line. Normally, it's at the level of the posterior commissure, 3 millimeter lateral to that. Here, as I already mentioned, that you can use the merging of the CT and MRI, and you can recheck and register this patient, and then you can get all your targets, the entry and trajectory. And this is after application of this, and here, after planning, this arc was attached with that frame, and then procedure is going on. This is the post-operative image in which in the ventral postro, this is the thalamus lateral to the this mid ventricle, and here in the ventral posterolateral area, the lesion you can identify post-operatively. So this is the target area. Next, please. So this was all about the stereotactic procedure. Basically, I try my best to make it simple. The same idea, either you will use you want to do a stereotactic biopsy, either you want to place an electrode, or you want to aspirate a lesion, or you want to do some kind of pain procedure. The principle is same from the early 20th century till the revival and late 20th century, and even in the 21st century, the principle is same. You have to identify your target. You must know in case of biopsy, as my topic was the biopsy, the target you will select on your CT or MRI. In biopsy, it's not necessary you will take biopsy from a single target. You can take biopsy from 2 or 3 points if you want to be make sure in with the same bar hole, but with the same trajectory, but with different this credentials. You can take the biopsy from 3 or 4 different areas. In the same way, you must know your targets. If this is for the placement of, if this is for pain or placement of electrode or for placement of any other procedure for making lesion for placement of DBS, then in that case, you must know that your target either you will select directly by using your CT or MRI, like in case of GBI, you can detect your target by this on the proton density image, and you can merge this with MRI T1 weighted image, where in T1 you can best select the anterior commissure, posterior commissure, and when you will merge it with the proton density, then you can detect directly where is the globus pallidus target. You can detect, even you can look for the external capsular lamina in between the GBI and GBA, Or in case of STN, you can identify the red nucleus, you can draw a Benjani line, you can go laterally 3 millimeter to that, and you can detect the STN. You can detect your target indirectly as well. Indirectly, either with the help of the different type of atlases. Even in the software, the important atlases are present. And according to the different head models, they give you the all the values for the placement of lesion or any target for placement of GBS, give you the clue. Like, for example, in GBI, it is like 21 millimeter away from the ACPC line and 2 millimeter just posterior to mid-commissural point and 0 in the same level, zero is 0. In the same way, the formula 3, 6, and 12 for the STN, these are available, and you can either calculate your target directly or indirectly. After selection of target, you will select your entry point, then you will select your trajectory. In that way, you will be at your target. Your software will detect, will calculate for you where you have to hit. It will give you X, Y, Z, as well as the arc angle and how much you should rotate your arc. And all these things will be helpful. And hopefully, as now, uh, stereotactic frames, they are available in almost all teaching hospitals. So it's a very good time to learn for the junior consultants and for the residents to do the stereotactic procedures. Thank you.
Thank you so much, ma'am. Thank you so much. Jazakallah for elaborating us very nicely and ma'am simply so that we can learn a lot. And ma'am
Most welcome.
कोई क्वेश्चन हो यार किसी दोस्तों को कोई भी किसी भी दोस्त को तो काइंडली मैडम हमारे साथ हैं तो काइंडली मैडम से
जी जी
पूछ सकते हैं. इसके साथ ये भी बताते चलें कि इंशाल्लाह नेक्स्ट मंथ के दरमियान में हम अ, एक वर्कशॉप अरेंज करेंगे स्टीरियोटैक्सी की अल्लामा इकबाल मेडिकल कॉलेज के साथ जिसमें मैडम लीड कर रही होंगी और
You are most
इंशाल्लाह वो
welcome.
इंशाल्लाह वो
Most
स्टीरियोटैक्सी पे ही
welcome.
होगी. एंड आफ्टरवर्ड्स इन
Most
आफ्टर
welcome.
रमजान इंशाल्लाह वी विल गो फॉर मिनी फेलोशिप एज वेल विथ अल्लामा इकबाल मेडिकल कॉलेज
Inshallah.
इंशाल्लाह इंशाल्लाह.
Inshallah. Most welcome.
मेरे ख्याल में कोई
Most
सवाल
welcome.
नहीं है. मैं बहुत ज्यादा शुक्रिया मैम आपका. हमेशा आप हमें
Either
सपोर्ट
the
करते हैं.
lecture was too easy or the lecture was very difficult. Either you got everything or the other option is no one get anything.
मैम मेरे ख्याल में लेक्चर तो आपने बड़ा जबरदस्त दिया और बड़ा आसान आसान लफ्जों में दिया. लेकिन ये है कि ये सब्जेक्ट ऐसा है कि हमें समझ इसकी थोड़ी कम है. वो ये है
Yes.
कि जब हम इसकी रिकॉर्डिंग.
Basically, I agree. I agree. Unless you will not use the software, you will zero knowledge. You have to use the software, you have to apply. If you want to learn stereotactic neurosurgery, then how to apply a frame and how to select a target, how to get the trajectory. Practical implementation is very important.
जी. सो इंशाल्लाह मैम बस वो आपके पास आएंगे वर्कशॉप में और इंशाल्लाह
Challenge,
उधर
most
जरूर
welcome.
आपसे. जी मैम एक मिनट देखो दो क्वेश्चन है शायद. अच्छा वो यूनिट प्रैक्टिकल ट्रेनिंग में डाल दे. जी मैम वो डॉक्टर
Okay.
अबरार हैं वो यही कह रहे थे कि हमें प्रैक्टिकल ट्रेनिंग में हेल्प
जी
कीजिए
जी
तो वो इंशाल्लाह वर्कशॉप और फेलोशिप
जी
के दरमियान.
जी
बहुत
जी.
ज्यादा शुक्रिया मैम आपका टाइम
My
देने का. जी जी.
Most welcome.
जी मैम.
Most welcome.
मैम आप
My
कुछ और बात
team is
कीजिए.
very active in functional neurosurgery. My associate professor, Dr. Nabil Chaudhary, my assistant professor, Dr. Kashif Sultan, both have good exposure to functional neurosurgery. My SRs, they are handling all the initial stages and they are good. Even my registrar is good in doing the frameless stereotactic biopsies, and they are good in that. And hopefully, you will learn a lot from here, inshallah.
इंशाल्लाह. थैंक यू सो मच. जजाकल्ला जजाकल्ला. अल्लाह खुश रखे. आमीन.
Okay. अल्लाह हाफिज।